the next about 30 minutes or so, we're going to be talking about obstructive sleep apnea, and we're going to do this in a case-based format. If you have any questions after reviewing this presentation, please don't hesitate to contact me directly at my email. And the objectives you can read here, and they're also on the canvas. So we'll start with our patient, who's a 45-year-old male who says that his wife made him come in because his snoring is driving her crazy. She says, "I snore every night and she can even hear me in the next room." And some Dr. Oz or something she watched, and she now thinks that he has sleep apnea. So he wants to know what sleep apnea is anyway. So what's the pathophysiology and definition of obstructive sleep apnea? Well, it's characterized by repetitive partial or complete closure of the upper airway despite ongoing respiratory efforts. And what happens then is you get episodic oxygen desaturation. The brain senses hypoxia and tries to wake you up. So there is sleep disruption so that you can start breathing. Anatomic factors, there's craniofacial structure and obesity. These are the most common. And what you're seeing is that normally during the day, the upper airway is well supported and maintained. But at night when we're lying down, the muscles of the upper airway relax, and so in certain patients, you get collapse of the airway, and then you get obstruction. So definitions. An apneic event is actually stopping breathing for greater than 10 seconds. Hypopnea is a reduction in airflow which actually shows brainwave arousal, or if you're looking at carbon dioxide increase and oxygen desaturation. And then you have your apnea-hypopnea index, which is the number of apneic or hypopneic events per hour of sleep. So you take a math thing to get your AHI. So it's the number of apnea and or hypopneas per hour divided by the number of hours you've slept, and greater than 5 is abnormal. So based on your apnea-hypopnea index, you get your severity of obstructive sleep apnea. And mild is between 5 and 15, moderate between 15 and 30, severe is greater than 30, and it's important that you know that there are 3 classifications because treatment is different depending on how severe you are. We don't exactly know the prevalence in the United States, but it's thought that there's about 20 to 30 million people, over 100 million worldwide. Men are 3 times more likely than women, although we're seeing that the rates in postmenopausal women not taking hormone therapy approximate the rates of men of similar body age and body mass index. Prevalence increases with age, especially if you're over 60, and that makes sense. Again, women over 60 are postmenopausal, and it's more prevalent among the obese. We think that the reason why we're seeing it worldwide in non-obese populations has to do more with genetics and craniofacial abnormality or differences. So Mr. A states he generally feels healthy, but he frequently finds himself falling asleep during meetings at work. And he says that more than once he actually found that he was falling asleep in his car while waiting, stuck in traffic. About twice a week he wakes up from sleep suddenly feeling like he's choking. And this past week his wife noticed several episodes where he actually stopped breathing at night. Now, what symptoms are associated with sleep apnea? Well, daytime it's sleepiness, headache, fatigue, impotence, depression, but the most common is sleepiness. That's going to be what people come in for, is daytime somnolence. At night, it's snoring witnessed apnea, choking or gasping that gets you actually to wake up. Risk factors we've talked about already, but obesity is the most important, and it's reflected in increased BMI and in the neck and waist circumference of your patient. So on exam, he has a BMI of 36, and he's hypertensive with a blood pressure of 150/90. His neck circumference is 40 centimeters, or between 16 and 17 inches. And you're unable to fully visualize his uvula or his soft palate due to an enlarged tongue sitting high in the mouth. So when we're talking about craniofacial features, we're talking about retrognathia or small jaw, tonsillar hypertrophy, elongated or an enlarged uvula, crowded or narrow oropharynx, or an enlarged tongue sitting high in the mouth obscuring the oropharynx. And we'll talk kind of on a side note about the Mallampati classification system looking at the oropharynx. So going back to this picture, and I'm sorry about the flip-flopping with the slides. Retrognathia, you can see the jaw is inset. Tonsillar hypertrophy, which you can see the tonsils are blocking some of the oropharynx. An elongated or enlarged uvula, again you're blocking some of the oropharynx. Crowded or narrow oropharynx just in general. And then an enlarged tongue sitting high in the mouth, also obscuring the oropharynx. On a side note, we'll talk about the Mallampati classification system. This estimates the tongue size relative to the oropharynx, and anesthesiology uses this to anticipate the difficulty of intubation. So as you go from a class 1, which is normal, to a class 4, which the doohickey here is blocking, where the soft palate's not visible at all. As you get closer to 3 and 4, there's higher association with obstructive sleep apnea. Again, this is used primarily with anesthesia to see if they're going to have difficulty intubating patients for surgery. Who should be screened for obstructive sleep apnea? The U.S. Preventative Service Task Force does not recommend screening the general population, but the American College of Physicians and the American Academy of Sleep Medicine have some recommendations. So the American College of Physicians thinks that you should screen if you have a patient with excessive sleepiness. The American Academy of Sleep Medicine recommends screening high-risk patients, so it's patients that not only have an enlarged neck or waistline, but are at high-risk occupations. For example, pilots or railroad engineers or taxi drivers or bus drivers or truck drivers are routinely screened to make sure they're not going to fall asleep at work, or if they're using heavy machinery, are not going to cause accidents. Our screening tool, they're more helpful for actually ruling out sleep apnea than identifying patients that have it. They're not as specific as we would like. And what we use is the Stop Bang questionnaire, which you can get at stopbang.com, but you'll see it here as well. Stop Bang is the mnemonic, and you can see that it's snoring, tired, observed apnea, blood pressure, body mass index, age, neck, and gender. And each one of these gets a point, and anything over 3 points is a positive screen. Our patient snores, he's tired during the day, his blood pressure is elevated, his body mass index is elevated, his neck size is kind of around 17, but he's male, so he has at least 5 points. Okay. He agrees to undergo further evaluation for sleep apnea, but he says he's anxious sleeping in unfamiliar surroundings, and he's worried that he won't be able to fall asleep in a lab. So let's now look at what tests are used to diagnose. The gold standard is a type 1 polysomnogram, and this is a 14 different electrical leads. It looks at your oxygen level and your EEG, so brainwaves, sleep cycle, and if you're having any chest compression while you're breathing and any nasal compression, heart rate, oxygen, if I didn't say that already. There's a whole bunch of different things. And we're watching you actually sleep, and we see whether or not you have apneic episodes, or if you're restless at night, or if you're snoring, or whatever's going on. We then bring you back if it's positive, and we hook you back up, and we start treating with oxygen, and we'll talk about that in a little bit. Portable sleep monitoring systems have been starting to get more acceptance, and these have been seen to actually be just as useful in patients with significant medical comorbidity. And what we're doing, there's a type 2, a type 3, and a type 4. The higher the number, the less it's actually testing. So the type 2 does not do the stages of sleep. The type 3 does not tell you how the respiratory drive is going, and the type 4 really only looks at oxygenation. And then some can actually order a nocturnal pulse ox, where all you're doing is literally sleeping with the pulse ox on your finger as a test. So some insurance companies will pay for that one instead. So this is what the type 1 looks like, and you can see our gentleman here is hooked up. He's got his pulse ox on his middle finger of his right hand. There's a monitor on his chest that's looking at chest excursion, one in his nose that's looking at whether or not he's getting any pressure from inhaling through his nose. He's got an EKG, he's on an EEG, and you can see there's a gazillion things being monitored here. He does not have any comorbidities, and his pretest probability was high. Again, he had 5 points. So a portable sleep study is okay. So he undergoes the sleep study, and he's diagnosed with moderate obstructive sleep apnea, which again means he had somewhere between 15 and 30 apneic hypopneic episodes. So before considering treatment, he wants to see if there's any steps he can take on his own. What can we recommend for him? Well, weight loss is shown to improve the scores and may actually eliminate the problem altogether with mild or moderate obstructive sleep apnea. You want to avoid alcohol because this suppresses the neuromuscular and arousal reflex responses and actually allows the upper airway to relax a little bit more. So you want to avoid alcohol for 4 to 6 hours prior to bedtime. Sleep positioning, supine tends to worsen OSA and snoring because the upper airway is more likely to collapse. So you want to tell your patient to sleep on their side or just maintain a non-supine position. Some people will actually recommend sleeping with tennis balls in your pajamas so that when you roll over on your back, it's irritating and you roll back over onto your side to avoid the supine position. So he comes back 3 months later after lifestyle modification. He's only lost 5 pounds, continues to complain of daily fatigue, and he's actually admits to a minor car accident when he nodded off in traffic. His wife actually hears him stop breathing as well, and she thinks that he may have a heart attack or something. So it looks like we're going to need to actually treat his apnea. The primary rationale for treatment is relief of excessive daytime sleepiness. But research has shown an association between an AHI of greater than 30, so a severe obstructive sleep apnea, and increased all-cause mortality. The sleep apnea may contribute to hypertension. There is an association with diabetes and stroke, congestive failure, AFib, heart disease and cardiovascular mortality, but it's been very difficult to establish if OSA is causing the association. Current treatment strategies, the first line is always continuous positive airway pressure, or CPAP. And what this is a nasal cannula or a mask that goes over the nose and mouth and consistently and constantly pushes air at a certain pressure into the airway. And how do we know what pressure we need? Well, that's when we're doing that two-step type 1 polysomnography. So Mr. A, for example, goes into a sleep lab, gets wired up with all those wonderful wires. They actually see that he's got about 20 to 30 for his AHI, and so the next time they bring him in, they hook him back up to all those wonderful wires, and they start giving him oxygen at a certain pressure. And they keep doing that until the apneic episodes disappear. Continuous positive airway pressure. Sometimes during those type 1 polysomnographies, you can do what's called a split test. So if your patient has such a high risk in the first couple of hours of sleep that you actually see an AHI of 30 or greater, after a couple of hours, they'll wake the patient up and start titrating oxygen right then and there. Now, there's variants of CPAP. There's an auto-PAP, which actually adjusts the pressure based on airway resistance. So as you start to inhale and take a breath, it senses the amount of pressure and it blows air into you based on the pressure that you're using to try to suck air in. Sorry. And then there's BiPAP, and BiPAP delivers two pressures, a higher one during inspiration and a lower one during expiration, so that it's easier to actually exhale, and it tends to be a little bit more comfortable just getting that blast of air when you inhale, as opposed to having an air hose blowing in your face all night long. The challenges with CPAP is adherence. Adherence is only 60 to 70% on a good day. So you want to identify early on if patients are having issues with masks, if their air's leaking around the mask, or if they have dry, irritated mucous membranes. Some patients will sense claustrophobia. It's just very uncomfortable for some people with these masks on. Other treatments, some people will use medication despite adequate use of the CPAP if you have residual sleepiness. There's also mandibular advancement devices, and these help to prevent the retroglossal collapse. And those have been shown to help. They look like this, and they jut the lower jaw forward so that you have a bit of an underbite, and that pulls the tongue, similar to what you would do in the jaw thrust with CPR. So it looks like this, and what you can see in the picture that kind of looks kind of MRI-ish, obstruction, but if you've got the jaw jutting forward, as you can see in the one called advancement, you end up opening the airway. There are some surgical options, but these are not recommended as first line. There's a uvulopalatal-pharyngoplasty, which basically you're removing the uvula and a lot of the soft palate and the tonsils, but fewer than 50% have improvement. Maxillomandibular advancement surgery, where you're moving the upper and lower jaw forward, has actually been shown to reduce AHI more than any other surgeries. And as a last resort is a tracheostomy, so that you're bypassing the collapsed airway altogether and your patient is breathing out of a tube directly into the trachea. Bariatric surgery has been associated with long-term improvement and can resolve OSA in some patients. But after weight loss, you should still have follow-up sleep studies to rule out residual sleep apnea before you discontinue the CPAP. OMT. OMT may have a usefulness here. There has been some myofunctional therapy used, which is basically training the upper airway muscles. So it's isotonic and isometric exercising of the upper airway. And using this as an adjunct with CPAP has shown to decrease the AHI by about 50% in adults and a little bit higher in kids. So this actually could be a potential area for further specific research. There are some other novel therapies which have been kind of need further study, but they've had some small trials and have shown improvement. We're not really going to worry about those right now. They're not in vogue. And that is the end. So it's important to know that not only are your patients that complain to you of excessive daytime sleepiness getting this done, but you do want to consider testing for obstructive sleep apnea in high-risk employment, and some of your employers may send you patients that will need to have the testing done because of the high-risk employment. So if you have any questions, this is a minor overview here. If you have any questions, don't hesitate to email me. Thank you much.